Hi, good afternoon. Welcome. Welcome to our NHMA Miami chapter meeting. Today we have a wonderful topic on COVID-19 as it pertains to Florida and nationally. And we're also going to be discussing vaccines and vaccine hesitancy. We have a wonderful panel of infectious disease experts who are here today. We're going to start with Dr. Elena Rios, who serves as our president and CEO of the National Medical Association, which represents 50,000 Hispanic physicians in the United States, and is also the president of NHMA, National Hispanic Health Foundation, which directs educational and research activities. Dr. Rios serves on numerous committees, including the National Hispanic Leadership Agenda Boards of Directors, NIH, U.S. Department of Health and Human Services, as well as the CDC Health Disparities Committee. Dr. Rios has lectured, published articles, and has received several leadership awards. She has been appointed to the Minority Alumni Hall of Fame of Stanford University and has been a fellow of the New York Academy of Medicine, as well as Institute of Medicine for Global Forum for Health Professions Education and the American College of Physicians. Prior to her current position, she also served as an advisor for the Regional Minority Women's Health for the U.S. Department of Health and Human Services Office on Women's Health. And this is a pleasure to have Dr. Rios host this event tonight, and she will be delivering our opening welcoming remarks.
Thank you. Dr. Bonilla, and thank you for your leadership in helping us to develop a very important chapter, the Miami chapter for doctors, residents, medical students, and others who believe in our goals and our mission of the National Hispanic Medical Association, which is really to improve the health of Latinos around the country. And I have to say, we'll probably end up going international at some point, but right now it's domestic United States. I have to say that the importance of this timing to discuss COVID-19 is important because now we have vaccines for booster shots, and we have vaccines for children that are just about to happen. And we also have at the national level a congressional discussion about the importance of the next decade. The next decade in our country is being debated on how important it is to build up not only the infrastructure of roads and bridges, but our internet and broadband, so that more people can reach their doctors through home care and home visiting through telemedicine. And it's also going to be very important to see the new job with the green economy and to have more jobs for building electric cars and other ways to decrease emissions so that we have less asthma and less respiratory disease, which we know COVID-19 is a virus that is a respiratory virus. And I think the other important thing about what is happening in Congress right now, and I'll just leave you with this, is that the Biden administration is calling this bill that will be debated this week, it's being called Build Back Better. And it's about future vision for families, for working families, that children should have preschool that's universal, that means free, and that families should be able to have some tax credits for children and other things, and to be able to have more ability to have lower prices of food and housing, et cetera, so that more working families can live with less stress. And I think it's the toxic stress in our communities that have developed into what we call health disparities, of course, with the social determinants of health that we all know about, such as poverty and lack of English proficiency, health literacy, lack of adequate housing or or and other things, and including immigrant status and issues of marginalization for Latinos in this country. But getting back to Miami, I think it's very important to grow this network, and certainly by having it virtual, we're able to bring the best and brightest to you today. And I want to thank Dr. Marti, Dr. Torres Madriz, and Ms. Alfonso from our office to be speakers today to educate you all about the latest on COVID-19 and what NHMA is doing and what we can do together with the doctors and residents and medical students of Miami. And I hope you all join us and join our organization, going to our website, nhmamd.org. The communication staff that we have done an incredible job in developing the website, as well as our portals and our newsletters. And we have a lot of information to share, and we'd love to share what you're doing with the rest of the country. So thank you very much.
So there is some housekeeping here. Presentations are going to be followed by a question and answer at the end. Please type your questions in the question and answer chat box, and participant microphones and video are going to be muted. Recording will be available next week at the nhmamd.org. And now it's my great pleasure to introduce our first speaker, Dr. Aileen Maria Marti, who is a distinguished professor. She is a physician scientist with decades of clinical and research experience. She has more than 45 years of research experience, beginning in 1976, with the work that she did with lemon shark, clinical research studies involving helminth infections, as well as drug interactions. She has worked on the health impact of vaccines, impact of Venezuelan encephalitis virus on humans. She has made great contributions to the studies on the pathogenesis of Ebola virus, as well as in disease surveillance and public health impact of disease, including legal, medical, and sociological factors. Dr. Marti has practiced clinical medicine, mainly tropical medicine in the nation of Americas, Africa, and Asia. She was also one of the 8 distinguished individuals on the Blue Ribbon panel that created the Military Tropical Medicine Course Program. This program has multiple annual med-ready operations worldwide, bringing medical teams of physicians trained in tropical medicine to deliver care in low and middle income nations. In addition to being a distinguished university professor with a joint appointment in case and translational medicine, Dr. Marti continues to contribute to the military tropical medicine education and training as an attending physician with the FIU FAST team as part of the U.S. Southern Command's Enduring Promise Initiative. Dr. Marti has served on multiple national, regional, and international boards, helping the World Health Organization, as well as working with the United Nations as a weapons inspector, and working at the White House for the National Security Council and as a presidential advisor. Dr. Marti continues to be an advocate and works with the COVID-19 pandemic. She has served as an advisor to several mayors of Miami-Dade County, and also works on multiple national, international panels advising on the pandemic science, medicine, and policy issues. It is my great pleasure to have Dr. Aileen Marti present her knowledge base and her expertise.
Can you hear me? I have absolutely nothing to declare. Thank you so much for that excellent introduction. First, I want to emphasize that there's a big difference between SARS-CoV-2, which is a virus, and COVID-19, which is a disease. Crowbar separation, guys, and don't mix them up. You can have SARS-CoV-2 in your system and you may not have disease, and the spectrum of disease that you may have from SARS-CoV-2 is going to vary for a variety of different reasons. So don't confuse the two. Why has this thing gone viral? If I may, if you allow me the pun, and comparing it to another outbreak that I was heavily involved with in 2002, 2003, and 2004, because parts of it that we did have a few extra cases in 2004, was the original SARS outbreak. The original SARS outbreak really put this set of viruses on the map for us as incredibly serious. And yet the grand total from 2002 to 2004 was 8,096 individuals. That's it. We have more than that in a day now of the SARS-2 virus. And 744 died, but the mortality rate was very high. But a key point about viruses, if there are too deadly, if they make you too sick, you're not out and about sharing. And so the fact that many people are out and about sharing and can even share this virus when they are asymptomatic or pre-symptomatic is part of the problem. Comparing it to MERS, which came out in 2012, which has a much higher mortality rate of 34.4%, because it's not easily shared. We had less than 2,500 cases and less than 858 dead, which is still bad, but nothing compared to what we're seeing now with a lower overall mortality rate. And we have upwards of 4.9 million people that we know of that have died of COVID-19. So the bottom line is that transmission rate drives the total number of cases. The total number of cases drives the number in the hospital. The total number in the hospital drives the total number in the ICU, and then the death rate and the long COVID symptoms. And we studied this back ages ago about recognizing when we were trying to understand pandemics that you have to take into consideration a variety of factors of the pathogen, and that these factors are going to have impacts beyond the healthcare system, as we have seen very clearly with the COVID-19 pandemic that has impacted the economy, our infrastructure, our security. And we have to be mindful of this. In terms of the disease that any particular individual gets or doesn't get from having contamination with the SARS-CoV-2 virus, it's going to depend on their environment. There's factors of humidity and temperature that alter things, and specifically which exact flavor of the virus enters your system. Do you have Delta, the Delta variant? Do you have the Alpha variant? All these things. And where has that virus been before? Because that alters how it behaves in you. And last but not least, and extremely important, are host factors. Our own genetic underlying conditions, what we've been exposed to before, can set up our immune system to work better or fail in this particular problem. And resilience enhancers, whether or not we eat well, exercise, sleep, all those things, and our age, all of it impacts on whether or not we end up in the hospital with this virus. And part of the pre-existing exposures now includes, thankfully, the vaccines. And so we see a spectrum of disease from you get exposure, but with a low dose and no cell entry, so you have no infection, or you get cell entry, but no detectable symptoms, all the way from mild to moderate to severe to critical. And a lot of it is based on our underlying immunity and the capability thereof. So what are we dealing with? We're dealing with a coronavirus, which is a big family of viruses that includes a number of different genuses and then subgenuses. And the particular SARS-CoV-2 virus belongs as the same group as the SARS virus in beta coronaviruses, which encompasses several other types of coronaviruses, some that just cause basically the common cold in most people, to the MERS virus we just talked about that's highly deadly. And there are thousands of coronaviruses. In fact, after the SARS outbreak in 2002, 2003, 2004, we became very interested in studying this, and we started to recognize newer and other forms of coronaviruses that could infect humans and that were infecting animals as well. So that by 2007, we already knew that this thing was a ticking time bomb, and hauntingly predicted, one of my colleagues did, that SARS viruses were ready to cause a much worse pandemic. And we unfortunately have seen this happen. So this is an RNA virus that's positively strand that is translated directly from the messenger RNA that is the genetic element of this virus. And it infects our cells, as we see here in this transmission electron microscopy, and it shares 82% identity with the original SARS virus. Remember, viruses are part of our ecosystem. Viruses are part of the circle of life. And viruses were here long before we were, and they want to continue being here. So they adapt, and that adaptation can be harmful to us. We're seeing here very clearly that there have been more than 500 different species of animals that are susceptible to the SARS-2 virus. So there's a tight interconnection between humans and animals with this particular virus, as well as impacts on the social determinants of health and the environment. So this is very clearly a One Health disease. Where are we today? As you can see, we have almost 45.5 million Americans that have had this thing that we know of, and 738,000, more than that, US citizens are dead, and nearly 5 million people that we know of have died of COVID-19 in the United States, in the world. And if you look at Florida and look specifically at Miami-Dade turns out to be, among all the thousands of counties in the United States, number 3. That's not something we want to be. Broward is not far behind. What's going on in the world? We still continue to see regional outbreaks. We're still seeing 2.8 million new confirmed cases in a week, with a grand total now, as I already mentioned, of nearly 5 million people who have died of this thing. And what's going on in terms of death in the United States is absolutely shameful. We have one of the highest mortality rates in the world from this thing. And why would we? We're such a wealthy nation, and we have so many resources and so many intelligent people. Well, the reasons include the fact of the nature of our population and the fact that we do not have a healthcare system. We have healthcare and we have scattered silos of healthcare, but we don't have a system. And the CDC has no teeth. And that's part of the problem. So it's a disproportionate access to healthcare in the United States, and mortality is very much centered on the policies that are applied that drive these numbers. And hence this wealthy nation, this beautiful nation of ours, is seeing an incredibly alarming rate of mortality from COVID-19, which is truly unacceptable. And if you look at what's happening now, the news is good. We're on a downturn. That's absolutely true. If you look at our hospitalizations in Miami-Dade and our particular hospitals, cases are way down from where they were before. And in terms of new COVID patients, they're few. Most, of course, are the unvaccinated. We always see a proportion of much higher with the unvaccinated than with the vaccinated, particularly that the unvaccinated tend to stay in hospital longer than the people who are vaccinated if we do have to hospitalize them. And in terms of children, we do still see an occasional child with COVID, and our wards were very filled up, the hospital wards for children over the summer. And now in terms of vaccinated or unvaccinated, just again to show you the proportions, you see the green is the unvaccinated, always much more unvaccinated people. What is driving the transmission? The virus continues to evolve. There continues to be a highly susceptible population. Less than 60% of people in the United States are fully vaccinated, if you count everyone. There is unfortunately increased social mobility. Well, it's also fortunate too, because it's also nice, but for the virus, increased social mobility and social mixing is a problem, as is the fact that there's inappropriate, inconsistent use of known public health measures and social measures, and of course the massive disinformation, much of which is very deliberate and very malicious, that people are falling victim to. We look at what the WHO is following in terms of variants. We continue to see a high number of variants of concern, and of course, there are some variants of interest that we're particularly monitoring because we see the potential to have breakthroughs with those particular, because they can be of a certain nature. If we had everyone vaccinated and or everyone previously exposed to COVID, we would not solve this problem. Even with 100% whole population immunization will not prevent the continued transmission alone. We need those other measures. We need those pharmaceutical, public health, and social measures to get this thing completely under control, which is what we want. But we have to do it judiciously at the right time, at the right place. And this is a really crucial point. And we've studied these measures, and we know that they work, and we know which ones work the best. Certainly, anything that enhances ventilation and anything that reduces the risk of inhaling the virus is going to be a positive thing for us and against the virus. Unfortunately, what we're seeing is as vaccination rates go up, the use of these public health measures and social measures is going down. And most strongly, the mask wearing is going down, facilitating greater transmission of this virus. So we cannot exclude that as a real possibility. What's going to continue to drive future trends? Well, population level immunity is still critical. Having good vaccination is absolutely critical, but the emergence of variants can thwart us, and we have to continue the appropriate use of public health measures and social measures at the right time and in the right place. People have argued that these vaccines are too new, and that's nonsense. The reality is humans have known about vaccines since ancient times, although they didn't call them that and didn't understand germ theory when they initially started to do the types of things that help prevent disease. But if you look at what's been happening in very recent years, you see that the development of new technology, especially structural biology, gene-based antigen delivery, high throughput sequencing, has permitted us to form the most amazing vaccines we have ever seen. So if you think about the development of the SARS-CoV-2 vaccines, it seems like we did it in a year or less, but it's not true. The truth is, we already 3 years before this outbreak had seen what had happened with Zika, had seen what had happened with other nasty infections, and decided to make prototype vaccines. And so a prototype messenger RNA vaccine was made and patented for the MERS virus that I spoke about earlier, which has a spike that's very similar to that of the SARS-CoV-2 virus. And so it was a simple, really a simple matter in science to use all that technology, that patented vaccine, and slightly modify the nucleic acids to produce the new Pfizer, BioNTech, and Moderna vaccines. And we also had technology existing for making viral vector vaccines. In fact, excellent viral vector vaccines have existed for over 25 years. In terms of stabilizing the spike, we knew how to do that 8 years before this outbreak happened. Advances in protein engineering, 15 years, nucleic acid vaccine development, again, 15 years in the making. Repeated response to pandemics had trained us to get ready for this. And so we had advances in this knowledge more than 20 years ago. And we started preparing for this horrific outbreak really in the early 1980s. And we drove that knowledge, all of it, that over so many years of so much intense science. For example, and many of these things led to Nobel Prizes, like the realization that we had to modify the messenger RNA in particular ways using pseudouridines. That led to a Nobel Prize. That's been incorporated in our messenger RNA vaccines. And that is a critical component, because when the Germans, a different German company, made a different mRNA vaccine and didn't add this modification, that vaccine failed. It only had about 35 to 40% efficacy. Another key finding by Jason McLean, who recognized that you had to stabilize the spike into a particular shape. He did his work with respiratory syncytial virus, but the concepts were absolutely the same. And we knew that we had to harden the spike, because the natural spike, if you expose people to it, doesn't quite get you the same level of immunity as if you harden the spike. Now you have a 14-fold increase in neutralizing antibodies. So this was all built into all these vaccines. And really, this is now a little out of date. From the 30th of September, there's now 320 SARS-CoV-2 vaccines in the world, with more than 20 messenger RNA vaccines of different qualities, some of which are now available to us, and obviously 2 fantastic ones are available here in the United States. In terms of the duration of immunity from natural infection compared to immunity from the wild virus, we do know that there is a very different scatter of immune response. And so we see the kinetics from the wild infection different than the kinetics from getting the, in this case, the Pfizer-BioNTech vaccine, which gives you a higher level of protection, although it seems to slip more if you only count antibodies. But you have to understand, not all antibodies are good. And when you see the wild virus, a lot of the antibodies that people form are actually bad for you. Not only are they bad, they are responsible for some people ending up in the ICU and other people ending up with long COVID. So we have to be very mindful of which antibodies we're talking about. And the antibodies that you get from a vaccine are high quality, neutralizing antibodies that do the job we want them to do. And that's really where the difference is. This is just basic immunology showing that the more times you vaccinate, the more cells and antibodies you have that can do the job. And that's why we've looked very carefully at the booster studies. And we see a key component of this, and I've tried to drill this home, is you need a higher amount of good quality antibodies to prevent colonization of the upper airways than the amount you need to prevent colonization of the lower airways. That's why we were still the vaccinated people were still able to avoid hospitalizations and ICU stays, but we're still getting colonized because their antibody levels had dropped. And that's one of the key reasons that we said, no, yes, the most important thing is the severe disease, but we also want to halt transmission. And if we want to halt transmission, we've got to get those antibody levels higher so that you don't colonize the upper airways. And that's part of what's going on. And of course, the VRBPAC has had many meetings, as has the CDC advisory groups. And as you are now all aware, the Pfizer and the Moderna and even the Janssen do have recommendations for individuals over 65 and those with severe disease that are 18 to 64 and those 18 to 64 which have occupational exposure. And so that's really quite a lot of people that are now eligible for the Pfizer and the Moderna booster vaccines. In terms of Johnson & Johnson, that should have been a 2-dose vaccine from the get-go. The reason it wasn't a 2-dose vaccine from the get-go had to do with policy-related issues. With 1 dose, you only get 70% efficacy. That's not good enough. That's why you're able to get the Janssen vaccine after 2 months, and you don't necessarily have to wait the full 6 months to get that second dose. Although lengthening it does help an individual overall have higher immunity, it's not the ideal thing for a pandemic where you want to get as many people as possible with high levels of immunity as possible the soonest. And so there's those competing things. There's also been the discussion of mix and match boosters, and the mix and match boosters are really important. And what we know about this is several things. There's no safety signal for mixing and matching. Studies were done in Spain and England and Canada and elsewhere showing that this works and that you get high level of efficacy and no safety signal. More recently, the NIH conducted a study that also showed that when you gave a J&J and followed it by another J&J, you got a 4-fold rise in protection, which is great, gets you up to much higher efficacy. But if you get the J&J and follow it with either Moderna or the Pfizer-BioNTech, you wind up with a 12-fold increase. And so because of that, the consideration has been made that mixing and matching, even though there's no formal recommendation, we are expanding the EUA to allow for that type of mix and match because it is a good idea. And clearly vaccination, this is data from the UK, but the same kind of data can be seen elsewhere, that vaccination absolutely lowers the death rate overall with the fully vaccinated people. A problem with vaccination is that it's not enough to bring the reproductive number, even the modified reproductive number, below 1. And that's why we continue to need the public health and social measures that we've been talking about in order to really get rid of this pandemic. In terms of therapeutics, we've gone over all the different ways. There's many excellent, like Brigham Women's Hospital has a fantastic therapeutic plan for COVID-19 at different levels and different stages. So does the WHO. I recommend you look at it if you are a physician treating patients. We're also working on new therapeutics, and we're studying, for example, so Trimavab is one of the anti-SARS monoclonal antibodies that's out there. There's several others out there. Everybody here has heard about Regeneron, which is a cocktail of 2 different monoclonal antibodies. Pfizer has an oral anti-SARS protease inhibitor, which goes with this moniker, this PF, and a bunch of numbers, which is looking very promising. The molnupiravir is a drug by Merck, which is an oral drug that's sort of similar in how it works to remdesivir. The only problem with it, it's pretty unstable, and so there's a little fear that even though it's very effective and fantastic at what it does, that it could affect DNA, unlike all the other things that we have there. So what should we plan for? We have to plan that this thing is still going to be with us for at least another year or two, and we have to do everything in our power to reduce it. Not only do we have to think about this, what's coming now, but what's next, because this is not our last pandemic. And one of the saddest things, I have been planning for all kinds of pandemics in my time with the federal government, with the military, and never in our pandemic planning have we ever considered political polarization as an issue. But the situation on the ground and the reality is that for the next pandemic, we also have to consider the problem of political polarization. And that completes my section of what I wanted to share with you.
Thank you, Dr. Marti. And we are going to reserve questions for the end. That was an outstanding presentation. Our next speaker is going to be Dr. Gilberto Torres Madrid, who is an internal medicine and infectious disease board-certified physician. Dr. Torres Madrid received his medical training at Central University of Venezuela in Caracas. This was followed by a residency in internal medicine and a clinical fellowship in infectious disease and tropical medicine at Vargas Hospital in Caracas. During that time, he served as an internal medicine staff physician and assistant professor. He then completed the residency in internal medicine at Albert Einstein Medical Center in Philadelphia, Pennsylvania. This was followed by a clinical fellowship and research fellowship, both in infectious disease at Tufts University, Tufts Medical Center, Boston, Massachusetts. In addition to his medical training, Dr. Torres Madrid holds a master's in science and clinical research from Tufts University, Sackler School of Graduate Biomedical Sciences. Dr. Torres Madrid is part of the South Florida Infectious Disease and Tropical Medicine Center. He is a specialist in infectious disease at Baptist Health South Florida, and he currently serves as a clinic assistant professor at Herbert Wertheim College of Medicine, FIU. As an author, Dr. Torres Madrid has published many medical articles, abstracts, and textbook chapters, as well as being an experienced researcher. He is a member of several professional organizations, including American College of Physicians, Infectious Disease Society of America, and serves as a board of director of the Venezuelan American Medical Association, which is a nonprofit organization that groups Venezuelan physicians working in the United States. Dr. Torres Madrid is also very fluent in English and Spanish, and it's a pleasure to have you here today.
Oh, thank you very much for this opportunity. Aileen, the presentation was great, outstanding, really enjoyed. And you set the bar very high for me. So we're going to talk about COVID-19, we're going to talk about vaccination, and we're going to also talk about how Hispanics are lagging with vaccination and how they are having worse outcome the whites. There's some disparity there. Okay, so I have no conflict of interest to disclose. I'm not receiving any honorarium or any money for this talk, and I don't talk for any of the companies that study or provide medication for COVID. I'm basically a clinician that I'm working mainly in Baptist Health South Florida so far by October 15, 2021. So my organization has discharged more than 21,000 patients. So we have a lot of clinical experience dealing with the patient, and we have seen how this pandemic has affected in different ways. We're starting seeing patients in March, and we always get full when the case is starting to going down and we're starting to relax the measure that we know work, like social distances and mask use, or we're trying to make a political statement with that. And as a consequence, then we had another wave in the summer of 2020, when we thought that everything was done, then boom. So we have in the winter a terrible experience in our hospital where ICU beds were full and patients were dying with COVID-19. Then in February, we got the vaccination. That was the CDC recommendation. The vaccinated people could remove the mask, and the reality is that everyone did. And then it happens, the Delta variants that came from India and then became the prevalent variant in the United States. And then finally we have the most recent wave, that is the wave of the unvaccinated. That's what we saw, the reality in the hospital, that more than 90% of the patients require mechanical ventilation, where patients they didn't receive the vaccine. Basically, almost all the patients that were dying were patients that were not vaccinated. Things nationally they are going down, but I want to remind the audience that we cannot be fooled again. So we know that we have to be prepared. As Dr. Martin said, we're not out of the wood yet. So we need to be prepared that we may have another wave in the near future if we don't do the things well and if we don't learn for our prior mistakes. Okay, so basically, so we have in the bottom part, so the test that we perform, we see how the cases basically followed by hospital admissions and death. Okay, so as Dr. Marti mentioned, just in the United States, we have 45 million of cases, and this horrendous number of 736,000 people. I mean, no a single war have killed more American than this COVID pandemic. I think in Hispanic, in the most recent census, we rose to be the first minority. Our numbers are actually like 18.5% of the population, but the coronavirus has impacted disproportionately Latinos population. So even though we're 18% of the population, so the cases are 26%, and when you have to do some math and some adjustment, sometimes this number can go up to more than 30%. And our outcomes also are worse. So we get more hospital admission and with death when we compare with the white non-Hispanic person. You see, and that is true for the Hispanic, but also true for another minority. Just to be Hispanic put you 1.9 higher risk of being a case. So just to be in contact with the virus and develop the disease, 2.8 times rated risk of being admitted to the hospital, 2.3 times rated to die complication of COVID-19. So this is basically mortality of the population adjusted, and basically in this kind of graph, everything around the zero is basically mean that we're following the average, the media. So in this graph, the first bar is the Hispanics. Everything goes up and positive. That means that disproportionately when we compare, for example, with the whites, that is representing in the gray. That's basically so being white in this country put you in less risk of dying from COVID-19. And this also happens with the non-Hispanic Blacks and with other minorities. And when we disclose this for ages, for age, it's the same phenomenon. So we have the Hispanics, all ages. So basically we're affected disproportionately worse than when we get compared with the non-Hispanic whites. And the same things basically, so same way to represent this data, and this is data from the CDC for the National Center for Health Statistics. So I think Hispanic. So we have a problem in Florida. 26% of the population is Hispanic or Latino, and we're contributing to 21 to 23% of the death. But when we weigh the population by the geographic area, sometimes that can go even to almost 40%. So this is more data from Florida. So far we have more than 3.5 million of confirmed cases with 58,000 deaths. So our curve of cases of the pandemic basically mimic what is happening at the national level with a big wave in the summer of 2020, again in the winter of 2020, and now with the most recent epidemic of the non-vaccinated folks that were filling our hospital and dying from complication of COVID-19, mainly for the Delta variant that was the variant dominant and still the variant dominant in the United States. So the cases in Florida, this is data from also this graphic from New York Times. So it's basically, so we see that now it seems that we're in better shape than like a month ago, when the daily cases and the death, they're slowing down. The hospital admissions also are down, and we have more ICU beds available for people, but remember not to be full this time again. So if we don't continue, if we don't keep vaccinating our population, and we're not keep with the measure of mitigation, like a social distancing and masking wear, so we're going to pay the price. So Hispanic population in Florida, we're 26% of the population. We contribute with 30% of the cases and 21% of the death, and we still low 23% of the vaccination. Non-Hispanic of Latino, there are the numbers right there, and they are recorded for no ethnicity, but basically I want to show how our important part of the population, but I mean, we're lagging behind on vaccination. Though we're going to show a graphic that we are doing better. Okay, so Dr. Martin already mentioned about the vaccines that are available in the whole world. In the United States, we only have the only two, the viral vector that is the Johnson vaccine, Johnson & Johnson, that is a modified adenovirus, and we have the RNA vaccine, the Moderna and the Pfizer ones. So far in the United States, there has been administered 414 million of vaccine with really few deaths and no too many major side effects. We have almost 200 million people fully vaccinated, but the number is still low. Only 58% of the population of the United States vaccinated. So what it means that we're still having 40% of patients unvaccinated that can be victim of a new variants, of a new wave. When we see by ages, so the elderly, I think they're smarter than everyone else. That's probably why they got to that age. So 65% above, 96% at least one dose. And when we see they are almost fully vaccinated, 85%. When we see the old ages, this number is down. And this number includes the elderly people that are in the 65 and up. So we need to do a better job vaccinating the younger people. So what we saw in our hospital was younger people dying or getting immediate complications for the vaccine, and the thing that they have in common is that they were not vaccinated. So this is a graphic that there's data taken for the CDC, but that was placing by the Kaiser Family Foundation, basically see the how has been over the time the vaccination and Hispanic and Blacks, African American, they're lagging behind when they're compared with, for example, with the white or with the Asian. Even though Hispanics lately, so we're doing slightly better than we did probably 3 months ago. Well, this number of Hispanic vaccinated, 51%, I think this number needs to go up. So in Florida, we're doing better than a national level. So national level, I said there was 58% vaccination. So we're here 61%. With 12 million, more than 20 million people that are fully vaccinated. So it's important, as Dr. Marti mentioned, and that is a message that we have to sell, that COVID vaccines are safe and effective. There are hundreds of millions of doses with no major side effects. There has been way fewer deaths in vaccinated people than non-vaccinated people. When CDC analyzed the data of the COVID-related deaths, that occurred 99% in patients that were not vaccinated. It's a formal recommendation to vaccinate everyone 12 years and older. Hopefully soon we're going to have recommendation for the younger one, the 5 to 12 years old, and older. The vaccine, the gates, we had to tell the public that this vaccine has been follow in safety. That's why we're taking so time and analyzing the data and to prove to the public that there has been a continued monitoring of the safety and that it's okay to have the COVID vaccination. So what are the vaccine hesitance and some of the barriers that we found? So not everyone that there is no vaccinated is an anti-vaxxer. So this is a data obtained by the COVID behavioral dashboard, and there was a survey in Facebook. Basically compare the answers, the way get it, where they didn't get vaccine from different countries. And the rate, the red one is the United States, and it's comparing about side effects. So the yellow one is the media of the country. So when you see in the United States, what's the one of the main problems is concern about side effects. So we had to tell people that do a better job telling that the vaccines are safe. The other thing that is important is also about religious belief. You see, so we're outlier compared with the rest of the world. So we need to involve the faith community to tell that getting vaccine is safe and it's okay. And we say the other thing, don't like vaccine, it's probably you don't have too much room to convince those people. It's the other thing that vaccine, they don't work. But I think probably concern about side effects and the religious beliefs is probably something that we can do. We can try to do better. Right? The other answer that we got is that they don't believe in they need a vaccine. And one thing that I want to share with you, most of my patients in this most recent way, that when we're admitted, they regretted not to be vaccinated. So because they believe that they didn't need the vaccine and they proved themselves they were wrong. So it's something that we had to communicate better. So to tell that it's okay to get the vaccine. And probably everyone could get benefit of getting vaccinated. So other probably barriers to vaccination. So we have to help people. So there are people that don't find vaccine appointments. There are people that they have the technical difficulties to handling phones. They don't have smartphones. People that cannot leave work, or people that have problem with childcare or have trouble getting away from school. They don't want to miss a single day of work because side effects. And there are people that were probably, they're going to get the vaccine, but they were waiting for the right time to get it. And the problem with waiting the right time to get it is that you can get the virus before the vaccine and pay the consequences. So I'm not gonna go too much about that, the type of vaccine that we have available, because Dr. Marti already mentioned, but the RNA vaccine. So they were proven in clinical trials to be highly effective, and they has been proven in real world to protect against admission and death, even for the Delta variants and all the variants that we have. Okay. In that, so these are the graph from the clinical trials that basically granted the approval. It was no ethical to continue an investigation when there was a clear benefits 2 weeks after the second dose of the Pfizer shot or the Moderna vaccine. So that needed to be available for everyone. Johnson & Johnson vaccine. So I'm gonna finish, and I think Aileen also mentioned this, and because the recent news is like CDC recommend a booster vaccination after 6 months in patients that are 65-year-old and older for the Moderna and the Pfizer vaccine. Adults that are living in long-term care setting, everyone who has chronic underlying medical conditions, and everyone who is working in high risk setting like us that work in a healthcare environment. For the Johnson & Johnson vaccine, a booster after 2 months, people that don't need to wait the 6 months. And also Aileen mentioned that missing and matching the vaccines are safe. The initial study for this vaccination were more for need, because they didn't have all the vaccines or had to hold some of the vaccine, but they proved that there was no problem with safety, and in some cases there was highly immunogenic response. Okay, so from this talk, COVID affected proportionally Hispanic and other minorities. COVID vaccination among Hispanics lagged but improving, but we need to do much better. Vaccines are safe, effective in preventing hospitalization, complications, and death, even in the presence of the Delta variant. And we need to identify the barriers for that vaccinations in order to increase immunization rate among Hispanic and others minorities. And that's it for me. And
Thank you, Dr. Torres Madriz. That was an excellent overview of COVID-19 as it pertains to Florida and nationally, and also covering information on vaccines and vaccine hesitancy. Our next speaker is going to be Jasmine Alfonso, who is a program director, who has over 9 years of nonprofit experience, specializing in program and project management, community engagement, strategic partnerships, and in running grassroots local campaigns. Jasmine leads the NHMA programs and communication staff forward to directly impact the Hispanic community, while also providing NHMA members and medical professionals with support, resources, and new opportunities to help better serve the Hispanic patients.
Great. Hi, thank you so much for that wonderful introduction. Hello, everybody. I'm Jasmine Alfonso, Director of Programs at NHMA. And today I'm here with you to talk about our Vaccinate for All campaign. I'm so privileged to be here today to be speaking to all of you, especially after the wonderful speakers that really set this up as we talk about our vaccination campaign at the National Hispanic Medical Association. Next slide. So at NHMA, we have launched a Vaccinate for All campaign. It launched in March of 2021 with our annual conference, and it is in partnership with the CDC and Johnson & Johnson. And the real purpose of the campaign is to really reduce vaccine hesitancy, build the confidence, and really address the structural and cultural barriers that are facing the Latinx community. So what we're doing with the Vaccinate for All campaign, we're really working to arm individuals, physicians, health professional associations, and more with resources, educational materials, as we continue to really grow our network. And to do that, we're growing our network with our Vaccinate for All champions. So we have 2 buckets here, individual champions. So that can be somebody like myself, my family member, who really just wants to help others to get vaccinated and really show and provide others that are hesitant with resources and information and tools on how to be able to do that. And we really work through these strategies through social media. There's so much misinformation out there. So NHMA is really striving to be the leader as a trusted resource for the Latinx community. And we also have organizational champions, which we're so proud of. And these are made up of our partners, of our medical associations, our Hispanic Health Professional Network. And we're just so excited to have them as supporting our efforts. And what we do there is provide them with Vaccinate for All materials, swag for events. A lot of you are speakers currently and speak on our COVID-19 briefing. So we really appreciate that. And we help support organizations on in-person events. Next slide. Great. So one of the ways that we're activating our champion network is through our NHMA chapters. We're so incredibly proud of our chapters and the community work that is happening on the ground to help these vaccination efforts. This is a grassroots mobile vaccination, homebound vaccination efforts that are taking place with some of our leaders, NHMA members, NHMA chapter leaders, and NHMA board members are all working together, volunteering to support vaccination events in their area. The one featured in this photo is from NHMA's Phoenix chapter, led by our member chapter leader, Ricardo Correa. So we're extremely proud of that. At this point, with those that haven't gotten vaccinated, it really takes going into the Hispanic community to talk to them, have these doctors who speak Spanish, that are bilingual and can really talk and explain to them exactly why it's important to get vaccinated, and they feel more comfortable. And so now we have to use other types of efforts in order to get those that are the most hesitant access and opportunities to get vaccinated. Next slide. So impact to date, we've had quite a robust impact with this campaign, and we're super proud of it. One of the ways we measure our impact is through our monthly COVID-19 virtual briefing series. So we've had 13 sessions so far, and we're so proud of those with over 3,000 that have attended. We have a total of 147 Vaccinate for All champions, as I mentioned. So 107 individual, 40 organizations. We've activated our local chapters, which we're very excited about, as I mentioned on the earlier slide. And then we continue to showcase all of the support and the Vaccinate for All champions and the events as we continue to do that through social media. We've also media trained 15 physicians. It's so important to be a trusted messenger and a resource within the community. So we really see the importance of that as well, and placing them in mainstream and local news. And then, of course, through social media, it's so important to put those positive and factual messages out there into the community as they see that on all platforms. Next slide. So we're really proud of our microsite. So I'll have put that in the chat box for you to review. So that's where you can sign up to be a Vaccinate for All champion. Please review that, see what our community is doing, read about our testimonial from our doctors, and really stay engaged with the campaign. So I invite all of you to really become champions in your own community and work with NHMA as we work towards this goal to get more of our community vaccinated. Next slide. Another really exciting feature is we've rebuilt our Hispanic health.info portal. So this is designed by NHMA and partners to share bilingual Hispanic focused health resources for providers, patients, and community members. So there's a patient side and the health professional side where we're really tackling a lot of health disparities, including COVID-19, cardiovascular disease, obesity, diabetes, HIV, influenza, and more. And so this is really an opportunity, as I mentioned, a trusted source within the community. It's so important that the Hispanic community knows where to turn for those trusted resources. And NHMA is really trying to fill that gap and really be where the community and where health professionals come to for the facts. Next slide. So as I mentioned this before, we've made a lot of improvements to hispanichealth.info. So we'll put that in the chat, and we're really looking forward to others to be able to participate and really utilize this great resource. Next slide. So we also have a Hispanic Health Professional Network. So we're really excited for that, as we're going to be continuing to have opportunities for medical associations and professional networks to work with us towards this vaccination goal, arming them with training of how to really communicate within their communities, and then also helping them with communications trainings. Next slide. Something that's coming up really soon that I want to make sure to flag is our 25th annual conference. So we're super excited that that's coming up. We're looking for speaker abstracts, poster presentations. So please check out our website. We'll make sure to put that in the chat box as well, as this is a great opportunity for others to connect and really to see what NHMA is focusing on for the future. Next slide. Okay, great. And then we have a COVID briefing that's actually coming up tomorrow. So I would love for you all to register and to attend. It's going to be like a tri-panel, and there's going to be a lot of great information that's going to be on this one, and really focus on how medical associations, the private sector, media can mobilize against COVID-19. So this is going to be a really exciting one that is coming up. Next slide. So that's the end of my presentation. I know we're at time right now, so thank you so much again for having me. Thank you, Ariel, for setting all this up, and Bennett, our program's intern, for helping out in the chat box. And I thank all of you so much for having me today, and I hope to see you all as Vaccinate for All champions. Thank you.
Thank you so much. I think we kind of ran out of time. Out of respect for everybody's time, we're going to conclude this session. And this session, it will be available, it's recorded. So we're going to go back and review the wonderful session. And thank you so much, Dr. Marti, Dr. Torres Madrid, and Dr. Rios for this wonderful opportunity. There's some other things here in terms of contact information. Please don't miss our annual Hispanic Health Professional Student Scholarship Gala, which is going to be held November 18th, as well as the NHMA 25th Annual Hispanic Health Conference, March 24th, 2022. Please join us as an NHMA member, or give a tax-deductible donation to NHHF or Amazon Smile Today. Thank you so much. One more slide here is, if you would like to become an NHMA advocate for ending HIV, you can do so. You can also participate in national and local events, connect with local CBOs to execute plan and testing drives. And here's the link below if you would like to sign up for additional information. You can contact Sophie Sibel.